This is the Shift Shapers Podcast, connecting benefits advisors with thought leaders and entrepreneurs who are shaping the shifts in the industry. And now, here's your host, David Saltzman.
You know, as we've all been sequestered, we've heard endlessly about the coronavirus, and it's COVID this and COVID that and COVID the next thing, and it's kind of blocked out the sun sometimes on some other problems and some other challenges that were there before and are probably going to be there after. One of them is the opioid crisis. It's not going away. Some may discuss the fact that it's actually getting worse. And the question is, what can you do? What can you talk to your employers about doing to help mitigate some of the costs? And there are apparent costs, and then there are other costs that are sub rosa. They're not really apparent, but they're taking a toll on plans. And with all the self-funded plans and the resurgence of interest in partially self-funded plans, it's something that you got to deal with. And so we invited Mike Vasquez. Mike is CEO and founder at Opioid Clinical Management. With that, welcome, Mike.
Thanks, Dave. Thanks for having me.
Let's level set a little bit, and because I think it's important to where we're going to go in the interview. Talk a little bit about your background.
It's kind of interesting. My background is actually healthcare IT, and so when I was very young, developed software that became the first electronic medical record in the U.S. with integrated AI and expert systems. Took that public on NASDAQ and then sold it to 3M Healthcare later. And from there, actually, at almost the same time, our oldest son's best friend died of a drug overdose. So we had time, we had resources on our hands, so we thought we would get involved in the community in helping people just through this local drug treatment program. But when we saw the results they were getting, they were abysmal, and it wasn't them uniquely, it was the national averages. And so we decided that maybe we should just start with a white piece of paper and look for the best evidence-based programs in the country to try and help people suffering from opioid addiction and from drug abuse. So fast forward 10 years, we ended up with the largest drug treatment program in the U.S., have 300 patients in residence daily, and 300 clinicians on staff, and then sold that company to a venture capital roll-up out of Nashville, and then found myself with in 2018 with all this experience of detoxing opioid patients, and obviously with a background in predictive systems and analytics, found a natural marriage of trying to figure out, is there something uniquely we could do here to try to be on the prevention side of the opioid crisis as opposed to the responsive side. And it's just a lot more interesting to be on the prevention side because people don't go through ruining their lives, finances, careers, and potentially losing their lives, as opposed to on the prevention side, you have a 100% success rate. So when you do prevent. So that's kind of what got me to found Opioid Clinical Management, which was the marriage of those two backgrounds of technology and actually treating patients. And our goal is for employers and health plans is to bring tools to them to help them do the same thing.
So level set for us. What's the scope of the problem, and is it getting better, worse, or about the same as it was a year ago?
You know, you continued to hear about the opioid crisis almost daily, and the deaths were rising. Interestingly enough, though you didn't hear about it because COVID, as you said earlier, sucked all the air out of the room, but you had about 80,000 deaths last year. And you're talking about a new record in the U.S. for opioid deaths. And I just was talking to somebody in the administration yesterday who told me that they're looking that it's going to exceed 100,000 lives in 2021. So we see a big wave in opioids, and not that this is the topic, but we also behind that see underneath the covers a big issue with benzos at the same time, because part of the issue with being sequestered with COVID is obviously opioid usage goes up, but one of the side effects of opioids is anxiety and depression as you start to come off of those, and the response to that is benzos. And then at that point you become sort of addicted, sort of the devil in the details, but it's either opioids or it's benzos. So I think we're in for a long run here as COVID is accelerated and impacted these issues, and I think we're in for a long run as we try to address them.
So how does this affect employees? I know there are some obvious effects, but you guys go a lot deeper than that, and you have a better understanding, a deeper understanding of the problem. Give us the scope of that in real time.
Well, let me give you maybe a step back to the roots of when we got into drug treatment is we found these data elements. And we saw as people came off of opioids, there was a chemical imbalance in the brain. And so that chemical imbalance really created a lot of indicators that we saw as people were coming off of opioids. The corollary here was the fact that we found that those were withdrawal symptoms. And withdrawal symptoms are defined as the lack of opioids in your system, as opposed to addiction, where addiction is actually I'm pursuing opioids with total disregard for consequences. I know if I keep taking opioids, I may end up in drug treatment. I know if I keep taking opioids, I may get arrested because I tried to doc shop. I tried to go to too many pharmacies, tried to get my script filled early. And so what we realized was there was a differentiation there that we had data elements of how the body responded during the lack of opioids or during withdrawal. And we found most TPAs and PBMs out there used addiction indicators, which just counted, well, this person tried to go to multiple doctors, tried to get their script filled early. But the problem was that was at the end stage. It was after all the costs had been spent by the health plan, after all of the impact to their life had happened. But we found that withdrawal symptoms gave us almost a 5-month head start. What'd that mean? It means that we could intervene and actually save a high percentage of the costs to the health plan and obviously the impact of that person's life. So we took our experience in a treatment room, picked up that patient and moved them into a cubicle, and then applied what we knew to show and treat them so that they didn't have the impact on their life as they went through their daily routine at work.
You know, in the open, I mentioned the resurgence of partially self-funded, or if you prefer, self-funded plans. And obviously, there's a lot of data that's available to plan sponsors that isn't available in the fully insured universe. And one of the things they can look at more granularly are costs. What are the direct and indirect costs of opioid addiction and then of detoxing afterwards?
I think the thing that people have been amazed at is, and we really had an eye-opener because, you know, we really thought we had something as we developed this. We went to employers and got a rude awakening. You know, the first response was that opioids aren't a big problem in our health plan. We haven't paid for a lot of drug treatment. It's not a big expense. And the PBMs have done a great job of reducing the cost of opioid prescribing for these employers. A good example is my wife had an appendectomy over the weekend. Obviously, they prescribed opioids. When I went and filled the script, it was $2. So opioids aren't a big expense for a plan. And so they were sort of ho-hum about the topic. What they didn't realize, and that's because they were using addiction indicators that PBMs and TPAs were measuring for them. When we sat down and had an in-depth discussion about the fact of, do you realize what the impact of withdrawal symptoms are, and the fact that 30% of every member of a health plan who's prescribed an opioid goes through withdrawal symptoms acute enough that they add on average $15,000 to that year, unrelated to why the opioid was prescribed. So blew my knee out playing flag football over the weekend. I'm going to have ACL surgery in a month. And now all of a sudden I'm on the opioids for a month pre-surgery, and I'm still on them after. And all of a sudden I'm seeing anxiety. I'm going to the ER. I have extended length of stays, complications. And so what we measured, we found 4 key indicators as we looked at, and those were indicators inside of orthopedics, indicators inside of general surgery, indicators inside of injury itself, and then chronic pain management. Inside of each one of those categories, we try to measure what's the baseline, what's your average as a health plan of ER visits, doctor visits, and hospitalizations in each one of those buckets. And then by implementing our strategy, we actually then can measure that, and we find we can reduce about 75% of the health plan spend, which could correlate to as much as 10% of the total medical spend tied to just directly to opioids. So it's been an amazing piece that we've evolved. And again, initially weren't sure that we even had something because employers were a little non-responsive as we approached them until they led us to analyze, which we do an analysis to validate those things I just talked about, that do they exist in your health plan? And obviously, since these are costs that are not being identified today, they're not being addressed.
That's interesting. So how as an employer or an employer with a knowledgeable partner such as yourself, how do you go about identifying those?
Well, we just filed a patent on our analytics, obviously drawing on my background. And what we did was we integrated into the analytics these unique withdrawal symptoms. And by identifying those, which give us that early stage head start. And so what's an example of that? So a good example is the fact that you may not be aware that there was a study done of about 1 million people by Dominion Labs where they studied people that were on opioid prescriptions. They found that only 1 out of 4 people were taking their opioid prescription as prescribed. What's that mean? 3 out of 4 people were not taking their opioid prescription as prescribed, and because of the short half-life, typically 4 to 5 hours of an opioid, they were unknowingly, unintentionally putting themselves into withdrawal. Again, right back to the heart of those indicators that we're measuring. So this is not an abuse pattern. This is not an addiction pattern. This is not an intentional prescribing indicator of a provider. These are the unintentional indicators that are happening just in everyday opioid usage when they're prescribed to people as they go along their day. And so what we do is we then identify those indicators, intervene prior to them having those additional healthcare encounters using just retail pharmacists. They're used to talking to doctors every day. Doctors are used to talking to retail pharmacists. And we don't really look to them to try to change clinical prescribing because we learned early on the last thing a provider is going to want to hear is us tell them how to prescribe opioids. But what we do is we administratively approach them on how they can help the employer implement a risk management plan. And oh, by the way, Dr. Jones, by doing that, you then will have a risk management plan yourself. We just did a large school district in Central Florida. We had 98% physician conformance to that because we approached them collaboratively to do that. And so that's typically been our results. And in that same school district, we reduced costs 75% in the cohort of people who were identified as prescribed opioids. So the results have been amazing.
So if the pharmaceuticals themselves are not the cost drivers, what are some of the cost drivers? Is it just the cost of what we know as a rehab program, or are there other cost drivers?
The cost drivers are what I indicated earlier. So the cost drivers are these unseen, unidentified healthcare side effects. So as some people are aware of drug side effects, some people are aware of drug interactions, and what the doctors aren't aware of the withdrawal symptom. We call these withdrawal symptom indicators. So now I'm on an opioid, and this is maybe a little deeper than some of the non-medical staff who may be listening, is the fact that when an opioid's taken, your body has its own natural painkillers called endorphins. But in the brilliance of the pharmaceutical industry, the opioid molecule exactly mimics the body's own endorphin. So when it attaches to the brain's receptor, the brain goes, oh, hey, this is a great endorphin, but man, it's hanging on for a long time. So the body builds up tolerance. Tolerance, by definition, tells the brain, listen, I must not need any endorphins because I have a ton of them, so let's shut down manufacturing. And by shutting down manufacturing, then, the next time the body needs an endorphin, there's none there. And the only way to solve or resolve that is to take another opioid. So it's a chemistry problem. It's not a weakness of character. It's not an individual weakness that a person has. It's a chemistry problem. And so we found and what the effect is when the body has a depletion of these amino acids, it responds by telling you that, listen, I'm going to make you feel miserable. I'm going to make you there's hundreds of symptoms that are tied to these depletions that we then have buried into our algorithm that we can uniquely identify because of our experience of detoxing 2,500 opioid addicted patients.
So if I'm an advisor and I'm helping an employer try to trim costs, and I start talking about this, you get the answer that you alluded to earlier, which is, hey, we don't see a problem. How do you get an employer, or how do you advise an advisor to get an employer from, we don't have a problem, to, holy cow, we do have a problem, we just didn't see it before?
Yeah. It's funny, that's the initial challenge we had as a question to ourselves because of just that reason. And so what we did was we decided to offer, and we offer this to every broker as they take it to a client is we actually can take the last 12 months of paid pharmaceutical claims, and then we come back with the detail of what is the impact of opioids from a withdrawal aspect to your health plan. No cost, no commitment, but it validates, is there an issue? So, for example, we just did a smaller resort in Florida this week, and we're getting ready to report to the client that, there really isn't a lot of big indication that you just can't handle on yourself. Converse, we had a large school district in Central Florida, and we saved $1.5 million in additional ER visits, doctor visits, and hospital visits because our pharmacists could intervene early enough to actually change the practice in those providers. Because one unique thing I'll say at this point is the fact that we get all of our outcomes, all of our benefits the provider or the employers receive. We never identify the member and we never contact them. The members of the health plan never know this is going on, or they don't need to know it's going on. It's happening transparently in the background. And that's the thing when I think when the employers really started to embrace what we do is because we could do this and not upset or disrupt the membership, as opposed to just get the outcomes. And to prove it to the employers, we do this at no cost and no commitment. And then once we show that where the data's at, because we do know all of the blind patient IDs, we can provide them back to the employer. They can audit and validate that. And then from that, then all of a sudden their eyes are open to say, you know what, the withdrawal symptoms, the opioid patterns inside our membership are creating costs that we never knew existed.
So you don't engage, I just want to make sure I understand this correctly. You don't engage at all with the members?
Never talk to the member, never even identify them. We don't even know who they are. Because what happens is now I will tell you, and this is a little bit of the secret sauce, is in the paid pharmaceutical claim, which is covered by HIPAA, and that's where the employers really pushed back. The provider who wrote the opioid scripts NPI numbers on that claim, that's not covered by HIPAA. So we're able to identify the provider who's creating these costs as opposed to the member who's experiencing them. And so by intervening to that provider, you could never afford to have us go out and work all of the providers in your network sort of looking for a needle in a haystack. And so what our algorithm does is identify those needles so that we can very efficiently go in and change and work your provider network. One of the big things our employers aren't aware of is the fact that opioids are a very complex prescribing challenge for pain management doctors. But what they don't realize is only 50% of their network, or 50% of their network, is not trained in pain management, and 80% of the opioids prescribed in their network is written by these providers. So what's the result? 30% of all the members written an opioid prescription suffer withdrawal because these docs have been trained on how to prescribe the opioid, the indicators that the Purdue pharma rep gave them on what to look for side effects, but nobody's ever been identified what withdrawal symptoms to look for and how to deal with them, because typically these are family practice, internal medicine, GPs, podiatry, ARMPs, PAs, and they've got 10 minutes with the patient. And what's my goal as a GP? Your satisfaction and comfort. So when you're in the exam room, I've got 10 minutes, you're not comfortable, it's just too easy to go ahead and say, you know what, I'll go ahead and refill the script. And so that's really where the employer gets the benefit.
So we've got about a minute and a half left. Where do you see the future? Where do you see the trajectory of this going?
We really see, obviously, since we're such a new startup, and you can think of all of the, because we validated the algorithm with a theory in 2018, developed it. 2019 ran about 400,000 lives through the program to fine tune the data points to make sure it was really looking and finding the data elements that we were talking about. Hit 2020 ready to run, and then COVID hit. So we then took the time to step back, found out that we validated we really had something unique that we had to invent to get done. So we filed a patent on the algorithm the fall of 2020, and it really just started to come to the market in 2021. So the point of that is the fact that your TPA, your PBM is not doing this because they don't have the technology that we have. And the second is you can become a thought leader in the opioid crisis to your clients, because it'll be the first time they've heard about this by you, the broker, bringing us to them.
Well, and as we talked about earlier, the savings is significant. And also there's a human cost involved that I guess we shouldn't overlook either.
Right.
So interesting. We hope as you roll out, you'll come back and talk to us and you can share some of the results with us. Mike Vasquez, CEO and founder of the Opioid Clinical Management. Mike, thanks so much for sharing your experience with our audience today.
Thanks a lot, Dave.